Robotic Urology Forum. This is fourth in the series. So this is about different techniques or different approaches for radical prostatectomy. And uh, I welcome all the faculty. So the Professor N.P. Gupta, Professor Chibbar, Professor Mahesh Desai, and Professor Shailesh Raina and others. So I can't enumerate everyone. So I think it's a pleasure to have you all in this webinar. And we have today a special guest. I'm going to introduce him. So can you see the screen, Ankita? Okay.
We can see.
Yes, sir.
Yeah. Okay. So we have today Professor Okan Tuju. He is a professor of urology and at Istanbul, Turkey, at Memorial Baslivel Hospital. And I was there with him last year. We worked. I was there for 3 days and observed all his surgeries. And you can see that he has got a vast experience in this surgery. So earlier he was working as president of urology department at SBU, Istanbul, Turkey, and he was earlier associate professor of urology at Saudi Konak Training Hospital. And he has around 98 scientific publication in international journals and 50 in national journals, and he has presented over 45 papers in international journal. So he's affiliated to numerous societies, so Turkish Urology Association and European Association of Urology. And he is doing this surgery since last 6 years, and he is expert in that. And let us see how he does. And in the end, once he finishes his surgical video, I think we can pose him questions. For request for all the viewers, you can pose your questions, and the questions will be taken up by moderator, and they will moderate. And once the moderator finishes their job, I think I'll request Professor N.P. Gupta and Mahesh Desai to give their comments and valuable inputs. So I will share the video.
He's here.
My topic is robotic perineal radical prostatectomy. "71 years old male, PSA level is 895. Transrectal biopsy is Gleason 3+3, 6, and history is he had a colon surgery and has hypertension. The patient was brought to the lithotomy position with 10 degrees of Trendelenburg, not exaggerate lithotomy. We insert the sterile globus into the rectum and we stitch the globus to the perineal skin. Thus, we aim to avoid rectal damage by using digital rectal examination during the perineal dissection. The position is very important. When we compare the transperitoneal robotic radical prostatectomy, you know the position is exaggerated lithotomy position. But the robotic perineal radical prostatectomy, this is only 15-degree Trendelenburg. Now we mark tuberosity sciaticus. We make semilunar incision now 6 or 7 centimeter. We make semilunar incisions, but the incision doesn't reach tuberosciaticum. We use cutter and we dissect and cut posterior fibers of the perineal body. We develop a plane in both sides of the central tendon for creating ischiorectal fossa. Now you can see. Now we are dividing central tendon. We move over the rectum in the most closest plane to reach the rectourethral muscle. Unlike Young's technique, we prefer Bell's approach. In this approach, the dissection is subsphincteric that causes significantly less bleeding and compared to Young's technique. By using finger dissection as well as tip of the sucker, we identified the borders of the prostate. In order to shine appearance of the capsule. Now we make subcutaneous push in order to place gel point. You can see. We must suspend these muscles with sutures. These sutures are fixed by hemlock clips over the skin to enhance the optical view during the surgery. Yes. We place the gel point and we use tripod. For the camera, an 8mm robotic trocar is placed at 12 o'clock and the other two robotic 8mm trocars are placed at 5 o'clock and 7 o'clock. Position on gel point. For assistance, 10mm trocar is placed at 6 o'clock positions. Now you can see port placed. We use only 3 arms in robotic surgery. Now the right side we use scissors and this is a prostate, the right side of lateral pedicle. We use hemlock clip. Now the right side of lateral pedicule. This is the left side. The left side lateral pedicule, and we use hemlock clips. Now, denovillar fascia was incised, was deferens were exposed. And dissect and cut bilaterally. Seminal vesicles are completely dissected and freed. Now you can see the seminal vesicles. This is a ductus. This is the right side, and yes, this is the prostate, the lateral side, the right side. This is the left side. Now we are reaching urethra. Dissect the urethra. Now we are cutting the urethra. You can see catheter. We place the hemlock clip on the urethra catheter. In order to keep balloon, inflate the inside the bladder to handle for further dissection. The catheter then is cut from the urethral side using a laparoscopic scissors. We never ligate the dorsal vein. This complex is released superiorly. As you can see dorsal vein, but superior of the prostate. Sometimes it can be open, but never bleeding because of the pressure. But if you perform open perineal radical prostatectomy, you can see bleeding. After completing the lateral dissections of prostate bilaterally, the bladder neck was identified and incised with monopolar scissors. Now we dissect the seminal vesicles, the lateral side. This is now we reach the bladder neck downside. Now the lateral side. Now we reach the bladder neck. Now we open the bladder neck. The urethral catheter balloon is cut by scissors and catheter was pulled out after anterior bladder neck incision. We remove the catheter. Now we insert the optic into the bladder to see the orifice. You can see the right side and the left side, the orifice. This is an advantageous for the prevention of an advanced injury of the orifice. Now we are cutting trigone. If the prostate volume is more than 60 cc, we can't perform open perineal radical prostatectomy, but the robotic radical prostatectomy, it isn't problem. You can do. Now it finished. We will remove the prostate. Now you can see the bladder hole. The right side, you can see the open vein. So we sutured, but you can see there is no bleeding. The lateral neurovascular bundle, the right side, and you can see the left side. Now we use modified von Hoffen technique for the vesico-urethral anastomosis. First suture is placed at 12 o'clock on the bladder neck from outside to inside, and then continue to the urethra from inside to outside, clockwise down to the 6 o'clock. You can see this is urethra. We can see bladder mucosa and urethral mucosa. Once the anastomosis is completed, a 22 French urethral catheter is replaced. The bladder is filled by 200 cc saline to test the anastomosis for leakage. After observing the water times of the anastomosis, robotic system was undocked and a Jackson Pratt drain is placed. Operation time is 110 minutes. Approximate blood loss 100 cc.
Thank you so much, Professor Tuju. I think it was really a great video for us, a new learning for us. With this video, I think you were not there when we introduced you. So I think I will call upon Dr. Persit Chibbar, Dr. Sudhir Raval, and Dr. Shailesh Raina to moderate.
Can we start? Can we start asking questions?
Yes, sir. Yes, sir.
Yeah, Dr. Volkan, my first question is, if you increasingly, depending on the grade of the Gleason grade of the prostate, if you want to do a lymphadenectomy, so what would you do if you think that a lymphadenectomy is necessary? That's the first question. Can you answer that, sir?
Yes.
Hello?
Yes. Can you hear me?
Yes, I can hear you very well, sir. I'm sure everybody else can too.
Okay. Yes, we tried the lymphadenectomy, but not extended lymphadenopathy, lymph dissection. Only limited lymph node dissection I performed.
So in general, you don't prefer. So what would be your indications for doing a lymphadenectomy? Is it the grade, or what would urge you? And if you find a higher grade, would you then go abdominally, or you always go perineally?
Absolutely. If the high risk prostate cancer, I perform transperitoneal robotic radical prostatectomy generally. But if the low risk, I perform perineal.
Two very small, quick questions. Was this all 0 degree, or did you ever need to use 30 degree, particularly on the posterior bladder neck?
Mm-hmm. Every time I use 30 degree up.
Okay.
Sometimes I use 30 degree down bladder neck. Sometimes, but generally 30 degree up is enough.
Okay, not 0 degree. You're saying 0 degree?
No, I never use 0 degree.
Okay, sir. Fogging, is it a problem? Because the cavity is rather small. So when you use cautery, you will tend to get fogging very quickly. Fogging, the lens getting fogged. Fog.
Yes. When I start robotic perineal radical prostatectomy, yes, sometimes I see the problems, but if there is no bleeding, no. But sometimes you can use air seal. Air seal, do you know?
Yes, we know air seal. Yes, thank you.
If you use air seal, there is no problem.
Can I ask you, Dr. Tolkon?
Yes, please.
It's a very good technique which you demonstrated. As there was some few innovation also. What advantage robotic perineal prostatectomy gives over open perineal prostatectomy? Exactly, what great advantage you have with robot?
First of all, if the prostate volume is size 60 cc and more, we can't do open perineal radical prostatectomy. You know, if the big prostate, it's very difficult to perform. But robotic perineal radical prostatectomy, you can do. I think it was published Journal of Endourology, 120 cc prostate, I performed robotic perineal radical prostatectomy.
Sir, any other question?
Yeah, there are plenty of questions. There's one question about your incontinence rates. I would presume they're good. So would you tell us how quickly do the patients become continent compared to a abdominal robotic?
Early continence rate is better, really, but the long, for example, 6 months later and 9 months later is the same.
Okay, when you say early, how early do your patients normally, after removal of your catheter, when are they pad free? Generally, I mean, earliest and latest.
Earlier, continence rate is better, earlier, but later is the same results.
Another question from Varun is that is nerve sparing possible? And are you making any definite attempts at nerve sparing, or is just the fact that you're going so close to the prostate and that you presume the nerves are spared?
I can do nerve spare because, for example, you never open the endopelvic fascia, and we never ligated the dorsal vein, so we spare nerve easily.
Okay. You made one point in the early dissection about your difference from Young's perineal prostatectomy technique. Can you elaborate that? I didn't quite understand what you said in that sentence.
Yes, I use generally Belts technique because of if you go through the suprasphincteric approach, you have very bleeding. You can see the bleeding. But if the Belts technique, subsphincteric technique, and surface of the rectum go through you can't see the bleeding. So it's the advantages.
So you go onto the surface of the prostate soon after you've cut the perineal tendon, and you do not. You are above the sphincter at that point.
Yes. Not the surface of the prostate. The lateral prostate. So you can see the or finger. You can. Palpations, you can, it's not difficult, it's easily.
Okay. Sudhir, Shailesh, questions?
Dr. Raina? Is there? Okay. Sir, I have one question to Professor Olkan. So, do you prepare rectum before surgery? Do you do enema? Do you prepare any bowel? And what are the chances of rectal injury in these cases, and also rectal incontinence?
We prepare the same robotic radical prostatectomy. All of them is the same. Isn't different. But I want to say advantage of the perineal robotic radical prostatectomy. After the operation, there is no pain. The patient, there is no pain is the bottom and the others. And stay hospital is shorter. For example, my literatures, my publications, all of them show that only 1 day stay hospital, then go to home. It's
That
very
means
important, I think.
you remove the JP drain on the next day. Or do you remove the Jackson Pratt drain on the
Yes,
next day?
yes, yes. 8 hours later, I removed.
Dr. Chibber, can I ask a question?
Please do, Amlesh.
Dr. Volkan,
Yes, please.
in your technique, anatomically, what muscles are remaining behind and what muscles remain anteriorly, which means what happens to the rhabdoid sphincter? The rhabdoid sphincter, I'm sure, remains anteriorly. But what about the transverse perineal muscles, the recto-urethralis muscle? What happens to these muscles? When you divide the central perineal tendon, there are so many muscles which are attached to the central perineal tendon. So what are the muscles that remain in front and what are the muscles that remain behind? That is, what are the muscles anteriorly, what are the muscles posteriorly?
Only my point is the rectum. I go through the superior of the rectum, but not go through the muscles. Only go through the rectum, superficial of the rectum. And I cut the central tendon. I cut the all of them, central tendon, and sphincter is the up, and I go through the under of the sphincter generally. But all of them superficial of the rectum. My point is the rectum.
And what about the latissimus? Oh, sorry,
And-
what about the levator ani?
Levator and I.
Levator ani.
And recto-urethral bundle I cut. The reach of the prostate before recto-urethral bundle I saw, and cut off the recto-urethral bundle, and then I reached the prostate.
Okay.
Okay, so Dr. Mahesh Desai and Dr. N.P. Gupta sir, so please give your opinions.
No, I like to ask.
Okay.
Okay, Mahesh bhai, you can tell.
So, I'm just going to give my opinion. Dr. Walton Tutsu is a beautiful demonstration. We could see all the anatomy, and we could see, because I see the indication where we have a abdominal operation or pathology before, where we cannot reach the prostate anteriorly. This is a beautiful way of doing it. I was so impressed that you have finished in 110 minutes, and that's very nice. You are not disturbed the anatomy, it out and then close it. And you also clarified that a large prostate is no problem in doing this perineal surgery. Now, I only want to ask, is there any different instrument you use robotically, or is the same instrument you use?
I use the same robotic instruments. Only I
Same
use
instrument?
yes, but I use 3 arm, not 4 arm. Normally, transperitoneal approach, we use 4 arm, but in this approach, only I use 3 arm.
How much pressure you keep?
The same.
How much pressure?
10.
So I really remember 2 cases where there was an abdominal surgery because of the intestinal problem, and he had a shear prostate. We could not do the prostatectomy, and we had to put him on hormonal therapy and radiotherapy. And in one patient, long time back, I did a HIFU to treat a urinary prostate. But looking at this technique, I feel it is a good technique to have in our armamentarium. Thank you very much. It was a wonderful demonstration. Now I give it to.
Hello. Yeah, Dr. Walker, I agree with Dr. Desai that you have given a beautiful demonstration of your technique of doing robotic perineal prostatectomy. The question I want to ask you, what is the learning curve for this? And it is necessary for somebody to do open perineal prostatectomy before going to robotic, or directly one can start robotic?
Really, I have a little experience of open perineal radical prostatectomy, but I have experience of robotic radical prostatectomy a lot. So I watch open perineal radical prostatectomy maybe 4 or 5 times, but maybe I perform one, but all of them maybe. But I perform robotic perineal radical prostatectomy, so I haven't any experience open perineal radical prostatectomy.
Apart from, you said high risk patient where lymphadenectomy is required, you cannot do it perineally. The question is there any other contraindication for this perineal approach for you?
I performed 20 patients lymph node dissections, perineal approach. So there isn't any problem or complications. But I performed, yes, I reached the external iliac vein and arteria and obturator lymph node dissections, but not extended.
Do you have any experience of doing perineal approach post TURP or post HIFU or post HOLEP?
I have one after radiotherapy. Only the dissection is the seminal vesicle dissection is difficult, and the other isn't there any problem, and it's very easy. After radiotherapy, only one case.
Thank you very much. We really enjoyed your technique of doing robotic perineal.
Thank you. Thank you very much.
Thank you so much, Professor Olkantukso. Be online, so we have further discussion. So now we'll move on to the next session. Thank you all the Mahesh Desai sir, NP Gupta sir, Prasit Chibbar, Dr. Raval and Dr. Raina. So I think we will move on to the next session. So what I thought was that, when we started doing robotic surgery, so slowly we are forgetting about open and laparoscopy. I thought that, we let us recollect what we have done, and they're the backbone of what we have learned today. So for to moderate this session, so I request Dr. Gaurang Shah, Dr. Ajay Sharma, Dr. Mohan K. Please call the speakers. Dr. Gaurang Shah.
No, it is not ours now.
Dr. Gaurang Shah.
Yeah.
Sir, call the speakers.
Yeah.
Dr. Gaurang Shah.
So first we are going to talk about laparoscopic radical prostatectomy, and I call Dr. Manohar T to demonstrate it or to show it. And then we will have an open radical prostatectomy by B. Kashyapi. So Dr. Manohar. Hello.
Thanks for the invitation. And I thank Viraj for giving me an opportunity. Sharing screen, I'm not able to see the.
Keep the video open, Manohar.
Yeah, I have kept it open.
And you see in that one of the links, you will see this video.
I think not getting that.
Yeah, we can see that.
Yeah, I couldn't see the video, but I'm just giving it for the PowerPoint presentation.
You can continue in the same PowerPoint, no problem.
Okay, thank you. So this is a 68-year-old gentleman with PSA of 19.2 and pathologic examination showed 4+4 with high-grade bilobar disease. MPRI with cadence surveys shows it's a localized disease and no bony metastasis. And this is the MPMRI shows the bilobar disease, and then you have some the disease extending into the right base. And this is the position, little 30-degree tendon and burr. And we use 5-port, 2 5mm, 3 5mm, and 1 working 12 mm and 11 mm for the camera port. Straight away going to the video. So this is the transperitoneal approach. And straight away, this is one first step important is to drop the bladder with the proper plane. Otherwise, you may enter too much into the muscle plane or too low. You need to see this cobweb appearance so that you are in a proper plane so that you can easily and fast enter into the retropubic space within 5 to 10 minutes. The most important time to spend is to get into the proper plane and just easy to peel off and enter into the endopelvic fascia. So you can see that, and then once you get into that proper plane, dissect of the periprostatic fat plane. You can use a bipolar, you can use a harmonic, and you can ligate it, and you can see that. And once you do that, you give a traction, and this is the right endopelvic fascia. Hook is a very good instrument in case of laparoscopically, where you can make a small incision and the pneumo enters into it, and it separates automatically the levator ani, and this is the lateral pelvic wall. Once you get into that, and you just have to enter proximally towards the apex so that you have a good leverage of control of the muscle and the lateral muscle and the medial prostatic plane. So it's better to start from the base and runs towards the apex. So this is very important step where we have to spend more time on that. I'm going to mention that how this patient incidentally had some kind of prostatitis, so that you can see that levator ani is little stuck at that level. So once you do it on one side and then go on to the opposite side. So this is the opposite endopelvic fascia and separation of the levator ani muscle. I just fast forward this. See that you can see that easily it can get separated. And the plane is little better here. Once you do that, then go more proximally towards the area. And this is a very important step which I would like to do in almost all the cases to separate the levator ani, especially to look for the urethral sling fibers. So most of the time in my experience of about 650 cases, of late I spend more time on to get into the urethral sling fibers, which I'm going to show in another few minutes. Once we do that, incise the puboprostatic ligament. Once, because since it is an uncontrolled situation, unlike in robotic, you just have to go slowly, little above. Give a continued traction onto the bladder using a bladder has been pulled towards the head end, and then you can see a good traction, and you can see the taut puboprostatic ligaments. So just inside the puboprostatic ligaments, a millimeter by millimeter, doing a vertical movement so that you can feel the tautness of the puboprostatic. Once you do that, then I think once again go and separate the sling fibers. You can see that you use a 30-degree and see these are the fibers which I'm trying to make out. These are the urethral sling fibers of the levator ani. For me, this is the most important step of the operation in getting the continence early, along with the length of the urethra. So I go spend more time on this area at the apical level, clear out all these tissues, and see this is the urethral sling fibers, and see that my needle has to come here. So I need to separate all these things away from, if I want to take any stitch, I would like to go here at this level. So spend time on this. Once you do the puboprostatic ligament, go near to the area of the apex, do a 30-degree rotation, and get onto that plane. Again, same thing is repeated onto the opposite side. Because the paucity of time, I just run through this. You can see that on the opposite side also, I'm just separating this puboprostatic ligament. They run like this, and this is the one. So once you do that, I think this is as simple. This is a CT1 half circle. This is preferably useful, very useful instrument for getting a knock over the DVC complex. I always do this step, and then just this is the state of a stitch. And once you do that, you save that, laparoscopically, you tend to see that there's not been blood. Some few cases are done cutting the DVC and stitch it later, but it's a little cumbersome to stitch it, unlike in robotic. So once you do that, so I always take you can see that this is the tautness. You give a traction here, and you can see that there is a mound of the detrusor apex. I take the back blade of stitch also, because while incising the bladder neck, you may not get into that plane of bleeding coming in the way. And also it defines, you can see that once you bunch that knot, you can see the base of the prostate coming onto the plane, and you can redefine this detrusor apron. So this actually detrusor apron not runs here, it almost runs toward the middle of the prostatic area. So there is one trick where one needs to go there, and I just pass forward this. So once you do that, then incise the detrusor from the middle of almost middle of the prostate, and run towards the slowly 30 degree towards the prostatic area onto the bladder, so that you can see that this is the vesical area, which is very well defined, and then you can incise that. Little of detrusor is still on the plane, but this patient did not have any median lobe, so I'm trying to incise that. Once you incise that, I usually use this dilator. It also acts as a retractor, so that you can lift up the prostate. Once you make the opening a little bigger, you can see that is the bladder neck, prostatovesical junction. You can just give a little leverage by inciting the detrusor on either side, so that you can view the opening a little better. And incise that. So use a hook, incise as deeply as possible. Once you see that prostatovesical junction, incise that, and this is a very good instrument. You can see that the Babcock's, one of the important steps is to make it as thick as possible, so that you hold the bladder neck. You tend to cut it more towards the bladder and make it thin. Rather than that, hold with the Babcock's forceps and make deeper incision 30 degrees towards the prostate, and straight away you will land onto the anterior denodular fascia. So you can see that once you do that, you hold with the Babcock's, resuction, divide the anterior denodular fascia, and you're almost there. So you need not have to, sometimes, you need not have to really cut through that. You just poke that by Babcock's, and then you can pick up the vas difference. So that's one of the very good instruments we're doing laparoscopically, using a Babcock's, and then you can start stripping the vas difference. You can just clip it, or you can do the harmonic for that. So both the vas difference run parallelly. And once you tackle the vas difference, you can hold them, and you can cut them, and then hold the vas difference both. Lift it up. Once you lift up the vas difference, you can see the vessels going towards the seminal vesicle. These are the vessels going towards the SV. So once you lift up give a traction to the SV, vas difference, the seminal vesicles start appearing with a traction, and you can cut them towards at the level, and you can do a scissor cutting, and it's not that difficult to do this once you keep the plane in place. So either you can use even a regular without cautery also. And once you divide that, all the whole seminal vesicle has been lifted up. This is the proximal end of the SV going towards the prostate. So slowly reaching towards the prostate. Once you do that, do the second, again, the same procedure is repeated onto the opposite side. And this is the this is the posterior denodular fascia here. One needs to divide this. This is the small vessels which has been ramification across the seminal vesicle. You may not find so many blood vessels, but in this case it was. So you can divide that, and then once you do onto the one side seminal vesicle, this is very important to incise these, take the complete seminal vesicle so that it acts as a traction, and doing it to the opposite side. And then divide this. This is the posterior denodular fascia. Once you lift up the both seminal vesicles upwards, then you can see a plane wherein towards you can just that. See that the left hand is pulling both the SV and seminal vesicles, then cut the posterior fascia and enter freely into the prerectal pad fat plane. That is the demarcation where one you can get it. So once you do that, you can use this curved scissor and start dissecting towards the prostate pedicle. So this is the scissor where you can go all the way up to the 3 o'clock position. You can just go all the way up to the prostatic position and flip the pedicle. So this is always done with the traction of both the SV upwards, and very important to give the traction. So this pedicle can be clipped easily, and all the time the assistant is pulling the bladder away from this area so that the vision is not coming under there. Now you put the 30-degree down, 30-degree up. You can see that then the most of the dissection, posterior dissection can be done with the posterior 30-degree upwards. And this scissor, this curved scissor, is also a very important instrument while doing laparoscopically because it runs around the mound of the prostate, and slowly, millimeter by millimeter, you can complete the dissection all the way towards the mullus muscle, towards the urethra. If the prostate is very small, you can just even cut the mullus muscle and get onto the urethra at this level. So if the prostate is big, maybe this may be a little difficult to go all the way up there, but then still it is possible. And what you can see here, this is the prostate is somewhere around 45 gram prostate, 45 to 50 gram. And we are able to reach that almost at that level. And you are always, and again, the same thing is repeated onto the opposite side. Here the pedicle is clipped. And then again, the dissection is carried towards the apex. This is onto the opposite side. There's a little much bleeding, and then you can see this is this is the little, what you saw that the disease was extending much here, so I go a little laterally at this point and preserving the neurovascular on the right side. And once you do that, the prostate is, all the minimal attachments are divided. And you can see that the prostate, when it starts moving easily and then divide this prostatic urethra, this is a puboprostatic ligaments, just give a good traction, and this ligament along with the fibrofatty tissue just retracts towards the pubic arch. And then slowly you can see that I have put a dilator here and just trying to get the least resistance, and usually the urethra gives away. And then you can see once you see the prostatic mound, and this is just to get the least resistance by putting a dilator so that I get a proper apical dissection. So we define the apex is that, so that you're almost getting a good length of the urethra here. And at the same time, I don't want to keratinize the urethra at this point. This is also the second important point for me to get the as much as length of urethra with the lot of urethral tissue without keratinizing it. It goes long way in tackling my continence status. And this is a very good see that this is the verumontanum here, and this is the prostatic apex. Even I would have saved a little bit of more prostatic urethra, but then it's a little bit more overzealous treatment. And then once you divide the posterior urethra, you can get onto the mullus muscle there. So just have to divide that rectourethralis muscle. And once you do that, you can just go laterally and divide that final remnants of posterior denovular fascia attaching to it. So this is completely which has been done, and of course in this case, in all the cases, we do a lymph node dissection. I'm not going into the details. I think because I think the time is short, I just go straight away onto the anastomosis. This is one side I show that it's going to clear the lymph nodes. This is the obturator nerve, and then this is the external iliac artery and the vein, and you can get from there. So all the way there, and then do it on the both sides, lymph nodes. Once you do it on both sides, and then now the anastomosis. It's also challenging scenario when you once started with the laparoscopically, but this with the 3-0 VLOX teachers made the life of laparoscopy suturing very easy. One important trick is to learn the suturing both hands. That way it makes life easier. And once you put the half midline, I take incision. I take the suture off midline from the bladder to the urethra, and then take the second stitch, same at the level, And then these are the 2 stitches. Once you take them, this is very important. Just a half midline I'm taking it because you're a right-hander, you would like to run through the prostatic area. I don't use any of the other methods of suturing the posterior inner fascia, rope postage or suspension. I'm quite comfortable when I get a good length of urethra and just, I don't know what has happened. Okay. Yeah, once you get into that plane of a good length of urethra and the separation of the muscles, I just want to do the anastomosis. Continence rate is almost nearly 90% in the first 1 month. In the last 100 cases, I think we have a continence almost near to the tune of 95% within 1 month itself. So you can use the right hand, so that you can use the right hand here and slowly you can run towards it. Use the left hand. Again, the left hand is very important. Use the left hand and right hand stitch. Both are important to take the stitches. It is always the watertight anastomosis. And again, the right hand. So it is very important to learn this technique of both right hand and left hand, and then you slowly run towards the 5 o'clock, 6 o'clock, 7 o'clock, and then go towards the 9 o'clock. 9 o'clock you go laterally, so you don't have to take more stitches at this level. Once you take that, and then you take a 3 o'clock, and then 9 o'clock, and then go to the 11 o'clock stitch. Then once you do that, it's very easy to do that when you have a good length of urethra. Then come onto the right side. This is easier now because you have done the most of the suturing onto the opposite side. This also you can do left hand. If the urethra is big, you can do a 1 swipe. And this is all done with 3-0 V-lock stitch. I use a 3-0 V-lock 2 stitches on either side. And this is the final stitches which has been taken. And once you do this completely, and then you can run anteriorly. This is the final stitch, anteriorly running from urethra to the bladder. So you can see that once you run all those things and then run from urethra to the bladder, these are all orchestrated movements. Finally, and so that there's no jugularity of the movements, there's no interruption of the movements. These are all orchestrated movements, going from one side to the prostatic urethra, and then from left side and right side, and join them and then complete the scenario. So this is how these complete anastomosis, and we also feel about 150 ml of this stitch may be required, sometimes may not be required in laparoscopically. You want to make sure everything clear and neat, and this is the bladder filling, and this is the final picture. Thanks for your attention. Yeah.
Please stop sharing.
Yeah, unshare.
Yeah. If you have any questions, I can take it now.
Yeah, Manor, can I ask you some questions?
Yeah, please.
Is there any contraindication for laparoscopic, for your radical prostatectomy? Which cases you will not do?
Which cases?
Yeah, whether very large prostate.
No. We have done large prostate. We have done up to 120 gram prostate. We have done post HOLEB. We have done post URP. We have done post kidney transplant. I mean, whatever the indication is right for the oncological principles, I think we have done that. Even for patient who had a large abdominal surgeries with adhesions, and we spent a little bit more time on that, and we have done that also. I don't find any.
And usually, how many ports you are using?
5 ports. There's a 2 main. One right hand working port is about 11 mm, and camera is 11 mm. Left 5 mm, and the assistance port is 2 5 mm. So 3 5 mm and 2 11 mm ports.
Manoj, can I ask you a question?
Yes, sir.
Yeah, 2 questions. You
Yes,
also do robotics, so you understand the ease of doing robotics. How do you fight getting tired in this surgery, even if it takes 3 hours or 4 hours? I mean, you're reaching across and your shoulders can get pretty tired in doing it.
Yeah, actually, I put on weight after getting the robotic.
Okay.
But then I think this case, what I've done it is about it exactly took about 55 minutes.
Okay.
So laparoscopically also we are finishing maximum 1 hour, 40 minutes is the maximum time limit, whatever the size of the prostate. So I don't think that time matters. But what I found when we did a transition into the robotic, I felt that I have lots of instruments because here I can pick up whatever instruments you want. You can have a hook, you can have a rectangle, you can have a clip, you can have a Babcock's. Enough instruments you can use in laparoscopically. Suddenly when you went into robotic and I
committed to using fewer instruments. Yes.
Manohar, can I ask you a question?
Yes, yes.
Yeah, how difficult it was there, the transformation from the laparoscopic to the robotic while taking that vesicourethral anastomosis, when it's especially when it's a narrow, the small urethra.
That time is decreased by 70%, 70 times it is decreased. Usually I take about 25 minutes in doing laparoscopic anastomotic suturing, but now here I'm finishing within 7 to 8 minutes in robotic.
And small urethras, no, intrapelvic length of the urethra, if it's small, how difficult it is?
Not really. I didn't find even a small urethras. We did laparoscopically, but then you put a little pressure and 30 degree down and you can really do that, but it takes a little bit more time. Technically, you can clearly see the posterior margin and you can suture it. It's not that difficult.
You mentioned the transplant surgery, post-transplant. So what do you do about the lymphadenectomy on the transplant side?
We are able to do that. We are able, because it's slightly away towards that. So if they have done the external iliac artery and anastomosis, it's not the internal iliac artery, external iliac artery anastomosis. So we have taken from that disease was about 3+4 and PSA of 5.5. It's a very low grade disease. So we're able to dissect up to from the junction of the external iliac artery and then go towards the obturator. We are able to do that on the right side also, but little difficult, but we didn't find that difficult not to proceed there.
So, are there any other question? I think there are no questions in the question answer.
Yeah, we'll go to the next one.
Yeah, I think we should go for the next one.
Can I start sharing my screen?
Yeah, go ahead.
Okay.
Yeah, Dr. Kashyapi.
Yes. Okay. Good evening, everybody, and I thank Robotic Urology Forum to give me this opportunity for showing an open radical prostatectomy in this era of robotic or laparoscopic. So this was a 71-year-old gentleman with a PSA of 17.8 and a biopsy of 3+4, 7, 3 cores on each side, 3 out of 6 on both the sides, and MP-MRI and bone scan and PSMA PET scan all showed a localized disease. So this is my video. I do it by fenestal incision, which is taken about 2 finger breadths above the pubic symphysis. You mark out both the anterior superior iliac spines. You could also do it by midline lower abdominal incision. I incise the anterior rectus sheath in a horizontal fashion and develop both the inferior flap and the superior flap. I divide the rectus abdominis from the very close to the symphysis pubis. This opens up the retropubic space. You'll get a few small blood vessels. You clean up the periprostatic or the pre-prostatic anterior prostatic fat to expose the anterior surface of the prostate. For a better retraction and a better visualization, the lower flap is taken, it's sutured, is retracted with the help of 3 or 4 sutures as you require, and that gives a wide exposure. This is with a cutting needle and a non-absorbable suture. Next step is the division of the endopelvic fascia here, beginning on the left side. You separate out the levator fibers, which could be coming onto the prostatic urethra.
similar incision is taken on the right side. Once both endopelvic fascia are divided, use a Babcock forceps to bunch up the DVC complex. Unless you have divided both the endopelvic fascia well, you won't be able to have a good bunching. I suture the DVC using a 10 vicryl. I generally take a stitch. I move down in between the patient's legs. I do it in a low lithotomy position. I go down, and that's because I'm a right-handed surgeon. I find it easier to take a stitch by standing in between the legs and facing towards the patient's head. This is a figure of 8 stitch. Once you divide that stitch, take a stitch, you take another stitch at the bladder neck. Again, I use a separate suture. Here it could be a 20 or even a 10 based on the how thick is the tissue there. After taking 2 sutures, that is one at the DVC and one at the bladder neck, the next step is for the division of the DVC complex. The curved scissor helps you with the initial curve pointed down towards till you reach the prostatic surface, and then you change the direction of the scissors to go under the DVC till you reach the apex of the prostate. There was a little more bleeding than usual in this case somehow. Once we reach up to the anterior urethra and the urethra is well delineated, you will now see I'll divide the anterior wall of the urethra to expose the Foley's catheter. This is the length of the urethra, what I have got it here, which seems to be fairly okay at the moment. I divide the urethra between the 2 clamps, and I take a traction suture or a holding suture for the lower end of the urethra. That helps me in using that during the anastomosis. And that also helps me taking out the clamp from the field. Next step would be the division of the posterior urethra and the rectourethralis muscle. This is the division of the urethra, and then the further step would be, once you have divided that, you will expose the denolvarus fascia. By gentle digital dissection, you are able to lift up the prostate and develop or define the posterolateral pedicles, which are divided between the clips, both on the right and the left side, by giving a superior traction. We then move on to the bladder neck. We again hold the stitch which we had taken earlier and use a small Ellis forceps to hold the surface of the prostate. By digital palpation, we are identifying the bladder neck, and then we divide anteriorly till we reach the detrusor fibers and expose the bladder neck anteriorly. It's a combination of a blunt and a sharp dissection using scissors or a cautery. This is defining anterior bladder neck, and you also separate the prostate. The Foley's balloon which was there, we now empty the balloon and These two ends of the Foley's help in giving a traction to the prostate anteriorly and exposing the bladder neck here. We'll be dividing here for dividing the posterior bladder neck, and then the detrusor fibers to reach into the space behind the prostate. This is generally more thicker than what we expect, and as Dr. Manoharan was making a point, you try to dissect or divide deep, then you will enter the correct plane. Majority of the times, the mistake we sometimes we do is we are too anteriorly or we are too superficial, not having reached the correct plane. Once we reach the correct plane, then you are able to identify the vas and the seminal vesicles, and you will be able to define the posterolateral pedicles, which are now being divided here. This is again one of the posterolateral pedicle. You are could either tight or suture ligate it or use a clips depending on whatever you are comfortable or the thickness of the pedicle. The right vas being separated. You can see the seminal vesicles also there. So between the clips you divide the right vas, also separate out seminal vesicles. Similarly, go on to the left side. I just fast forward. Now this is the left vas being separated. This is the completed specimen. The right seminal vesicle was bulkier on the left side, both the vas. The next step would be approximating the pararectal tissue. This gives a posterior support. I generally do it in most of the patients. I use a 2-0 vicryl starting at the apex of the or very close to the urethra and coming up, either interrupted or continuous sutures. The next step would be the eversion of the mucosa at the bladder neck. The bladder neck was quite wide in this patient, so I use a 3-0 vicryl to evert the mucosa all along. A good eversion is helpful in anastomosis and reducing the chance of bladder neck contractures. Now I begin the urethrovesical anastomosis again using 3-0 V-lock sutures here, following the techniques developed in laparoscopy and in robotic. Similar to what Dr. Manoharan showed, I use 2 V-lock sutures, beginning outside into the urethra and inside out from the bladder neck, and this suture would be run clockwise. While another suture I start from the bladder neck outside in and then inside out from the urethra, and which would be run anti-clockwise. This is locking the suture through the loop. This is again on the right side. Once both the sutures are taken, then I gently pull down the bladder neck, the posterior bladder neck, to join the urethra so as to form a good posterior lip. This is most important. So sometimes you could take 1 or 2 throw of sutures, but generally one each on each side is enough. So this is the second suture on the right hand side, and this is the bladder neck which has been slipped down and approximated to the urethra here. This is the cut end of the initial urethra, what we the Foley's catheter what we had. So after 1 or 2 sutures, I change this Foley's to a regular Foley's. So I have taken further throw of sutures beginning on the right side, that is on the right side of the screen, or the left side of the patient is going clockwise, while on the right side of the patient I am going anti-clockwise. Once we have a good posterior lip and few other sutures, then I change the Foley's to a more definitive, I generally use a railroad, or many times if there's a good lip, it will straightway go in. So this is the Foley's which is coming through the urethra. I guide it into the bladder neck. Once the Foley's is there, I inflate it to about 10 cc. Now this is the remaining anastomosis. The urethra is well seen. the Foley is not stuck, and then I go on to complete the rest of the anastomosis. Depending on how you find it comfortable, either going clockwise, anti-clockwise, to reach up to the midline here, and then subsequently we will close the anteriorly the bladder neck. The same one of the sutures is used to close the remaining of the bladder neck. The bladder neck was wide here, but that really doesn't matter once we close it anteriorly. In fact, this wide bladder neck was helpful during the urethrovesical anastomosis. So this is almost completing now. This is taking anteriorly. I do take a part of the DVC also in this. This will go on to almost, the bladder neck is now closed anteriorly. So this is almost one or few sutures at the. I generally don't tie them, these being V-lock sutures. I give them a traction and then cut them off. I check the anastomosis by filling up about 200 cc with the help of a 2-meter syringe. I also check that the catheter is not blocked. This is the urethrovesical anastomosis. And finally, the closure is done with a monochlor closure with 1,0-vicryl after putting a drain. This is a penicillin. So thank you very much.
Thank you, Dr. Kashyap.
Yeah.
This is, feeling like good old times.
Yes, sir.
Time surgery, laparoscopy, and the open surgery. And hats off to you. You could manage a very, very beautiful video of open surgery, which is generally not possible. So, any questions?
Yeah, I want to ask one question to Kashyapi.
Yes, sir.
Because you are taking continuous sutures with the catheter in,
Yes.
what are the chances that you will go through the catheter?
I changed my catheter after I have taken very well the posterior lip. The chances can happen. So when you are actually taking a stitch, you can ask with the help of a forceps, you can take it away. So that is also in one of the steps I showed. I moved the catheter up and anterior and posterior lips. If it is gone through a stitch, it won't move easily, but that chance can remain, sir. There are different ways to. There are different ways to avoid that. Either you can use a catheter, you can put a dilator. There have been described a technique of putting a cystoscopy sheath so that you don't include the opposite side of the urethra. Different techniques are there, whatever you are comfortable, sir. One is comfortable.
Can I ask one question?
Yes, sir.
And you take the penetrant incision, correct?
I take a penicillin incision. I find a much better, wider exposure. I can do a lymph node dissection also very easily through that, sir.
That's only what I wanted to ask you, that how easy it is to do lymph node dissection with.
In fact, it's much easier, and the exposure to the prostate and the bladder neck, I find it much easier than a midline abdominal incision, sir. The only problem this can happen with some incision, there is about a 5% incidence of an incisional hernia.
Now, I'd like to ask a question to Kashyapi.
Yes, sir.
You have shown nice open. We have seen laparoscopy and robotic. I'm sure you must be having robotic. So how you decide which one to do? It's all because of the financial of the status of the patient or anything else?
No, it is not only the financial status. I do not yet do robotic surgery, sir. I have a colleague with whom I can do a laparoscopy. So I do offer both the choices, laparoscopy versus robotic. Sometimes it is the patient decides, sir.
Yuvraj, can I ask a question and to that to anybody who wants to answer?
Yes, sir.
Does anybody have experience of the detrusor apron sparing hood that is described by Ash Tiwari?
No, sir. I have not done it.
You know about it? It is.
Yeah, I know about it.
I like the retro sparing.
Percy, I know about it.
Done retro sparing. And from the front.
We try to do the detrusor apron, and definitely we can find out it also if you dissect it carefully. And at the time of Rocco stitch, we like to use that actually, using in our Rocco stitch. So that detrusor apron theory is right, and it is available actually, and it may give you better support to your anastomosis and all that.
Sudhir, not tried it. Sudhir is there or not there? Raval?
No, he's not there, sir. He's not there. He's just like. Okay, so I think almost
I've got
all
a
the
question. Hello.
Yes, sir.
I've got a question for Dr. Kashyapi.
Yes, sir.
How soon can you usually discharge your patients? What's your discharge policy for these?
I discharge once I remove the drain, which is anywhere between 4 to 5 days, sir. And they are once well ambulant. I
And
take
how-
out the catheter between 10 to 12 days, sir.
Okay, I think we can wind up this session. We have to move on to the next session. Kashyapi, one question I think from the audience. Yeah, when you're taken the DVC stitch, if the stitch slips away, what you will do? How do you take the control of DVC? Hello, your voice is muted. Kashyapi, your voice is muted.
I will unmute it. Okay, now. So if my stitch cuts through or if it slips, I will catch it again with the Babcock forceps and take another stitch.
Okay.
The Babcock helps in giving a good hemostasis, so there is no panic there. And somebody from above can, as I mentioned, I go down in between the patient's leg lithotomy and then take a stitch. So that he gives me a good stitch actually.
Yeah, I think it happened to me once, and I think perineal pressure will bring everything out, and then we can take a horizontal stitch rather than a
horizontal. That is what I find that easier taking it from the lower end.
Okay, Kashyapi, last question for you.
Yes.
We have learned even in Tata, I think you might have learned from Dr. Jagdish Kulkarni. So he generally, and we also generally take 6 separate stitches for urethrovesical anastomosis. Now we are converted into a continuous one. How comfortable or easy is it?
I'm more comfortable with the continuous stitch with the availability of a V-lock sutures.
Okay, before
This
that,
modification has come after watching the laparoscopic and robotic one.
no problem. Okay, thank you. I think we will move on to the next session. So now we have series of 3 cases. So I will call upon the first presenter. I'll just go through that. Yeah, Dr. Mujib. Hello.
Hello, Dr. Yuvraj.
So the first case presentation will be by Dr. Mujib, and we have Dr. Volkan Tuksu, so again back online. And then we have Dr. Kalyan Sarkar, and then we have Anshuman Agarwal. So go ahead with the case and please be on time. So only technical and clinical and practical points we want to discuss.
Yeah. Thank you. Thank you, Raf. I'll introduce my panelist. Yuvraj has already introduced Professor. I request this only 15 minutes is there. We'll try to minimize it to 12 minutes on the case. And I request the panelists to be specific onto the point. I'll just present this. The case was a 48-year-old male in good health, presented on November 2016 with low backache. And he was evaluated and was found to have a PSA of 30 nanogram per deciliter. This MP-MRI was done. There was a lesion in the left lobe of the prostate in the mid-zone, 2.3 into 2.2 centimeters with extracapsular extension. And nodal, there's a regional bilateral nodes were positive, and there was a left common iliac node of 1.2 centimeter. The trust biopsy was done, which showed an 5+4 ISO 5 grade. And bone scan, single lesion at T5 vertebrae. I'll summarize this thing. 48 young person with good health, with high risk, high Gleason, nodal positive with extra regional nodal mets in the left common iliac, and a single bone met at T5 level. That is M1B. So I request Dr. Professor Kalyan Sarkar, like what will be the initial management of this case?
Dr. Kalyan Sarkar, unmute.
He's a young man with a very high-risk disease, and I would like to actually have a cross-sectional imaging of the whole body. So a whole body chest and abdomen CT with contrast. I would certainly like to do, and I would also like to do a MRI focusing on the lesion on the D5 vertebra to look at its nature, and then proceed further after informed consent.
Evaluation wise, you want a CT or MRI of the whole body? MRI.
I want
You
to
advocate the PSMA PET in this this
yeah, it
first line?
it was 2016. The PSMA PET CT is now standard in 2016.
Okay,
I'm not sure whether PSMA PET CT was right.
So what would be the first line of your management?
I think this, faced with this problem now, I would certainly get hold of a whole body PSMA PET CT, which would give me a little more practical management. It's high risk disease, and I want to be really sure that this is this patient has a low or a high metastatic burden. So that has to be clarified. Having said that, he would need androgen deprivation therapy. We instituted along with, I think the recent trials are indicating the use of the newer anti-androgens or chemotherapy. So these are
which one do you prefer, sir? Is a surgical castration or a medical castration? And if the medical castration, which one you prefer?
Well, at this point in time, I think he's 48 in good health, does not have cardiovascular disease. I would probably start him straight away on an anti-androgen along with an injection of LHRH analog.
Yeah.
And so I think he would be an appropriate.
Okay, sir. I'll come back to you, sir. Dr. Anshuman, what is the role of a young man with high-risk disease, chemotherapy, the role of chemotherapy as per the trials?
Yeah. So thank you, Mujib. So I mean, this guy has got, as you have said, that this guy only has bilateral pelvic nodes, and there is no bony. There's a single bony metastasis.
Yeah,
so I would agree with Dr. Sarkar that the preference would be hormonal therapy. Yes, this is a very high risk individual, 48 years, PSA 30. Definitely with PSMA PET CT or PSMA PET MRI, we may come up with newer lesions, because this has been our experience that conventional imaging versus PSMA, and you come up with newer lesions, which specificity may be doubtful, but then you correlate with the CT or with the MRI, and you can be reasonably sure that these are bony metastases.
Yes.
So something which is oligometastatic on a conventional imaging can be with a high metastatic burden disease on a PSMA. So in that case, if there's a high metastatic burden, or if there's a visceral metastasis coming up into the liver or somewhere else, one would definitely prefer the chemotherapy. But otherwise, one would go with a combination of LHRH, agonist, antagonist, or GnRH, whatever, along with abiraterone or enzalutamide in this patient. In addition to that, what I would want is, we have a biopsy result. I would want to rule out any neuroendocrine elements associated with this, which will again tilt me in favor of a chemotherapeutic along with the pattern additional. In addition to this, because the PSA is 30, there's a high chance that he only has adenocarcinoma.
Yes, sir.
But you never know.
In that point, sir, based on the chartered trial, this PSMA PET was not considered to gauge or to measure the number of bone mets, isn't it?
Yes, absolutely.
Yeah. So, which chemotherapy you would like to give if it's chemotherapy?
So if the chemotherapy is a consideration here, then we would like to start with docetaxel. And since this is a young man with a reasonably preserved status, so a 3-weekly regimen of 75 milligrams per meter square. Although personally I don't know my chemotherapies, but I get into collaboration with our medical oncologist to do the chemotherapies.
Yeah, when usually you assess on chemotherapy, you started say 6 cycles of docetaxel. Then when will you assess the PSA at that time? How will you assess the response to the chemotherapy?
So at least after 4 cycles.
Yeah.
After 4 cycles, we would like to reassess the disease. Also, if somebody has clinical symptoms, for example, if he has a pain, then you assess the response to the pain. If he has, a PSA high, then you assess the response to PSA. And I would wait for at least 4 cycles, at least to be able to assess any response here.
If there is no response to the chemotherapy, this docetaxel after 4 cycles, you will stop. You will not continue with the remaining 2 cycles.
Not at all. Yes.
Okay, sir. Professor Volkan, what is the role of radiotherapy in this low volume castration naive prostate cancer? Radiotherapy to the primary. Is there any role for the radiotherapy to the primary prostate as well as to the nodes? Based on the Stampede trial.
Yeah, Professor Volkan, you have to unmute. You have to unmute.
You have to unmute.
Yes. Can you hear me?
Yeah, it's clear, sir.
Yes. You know, the Stampede trial showed that prostate radiotherapy did improve overall survival in these models. So, but generally, my opinion, I prefer the surgery.
Yeah.
You know, this is the oligometastasis.
Yes.
So we can do radiotherapy only lesion of the bone.
Yeah.
And radical prostatectomy and extended lymph node dissection. But this case, I think 2016.
Yeah.
So when the patient came 2016, maybe we can do only hormonotherapy,
yeah,
and then maybe radiotherapy.
Okay, sir. So this NCCN, what the NCCN says for the treatment option for men with M1 castration nape disease, orchidectomy plus docetaxel or LHRH agonist plus docetaxel with first generation anti-androgen for more than 7 days to prevent the flare, and LHRH agonist plus first generation anti-androgen plus docetaxel or antagonist with docetaxel. If you are going for a surgical castration, orchidectomy plus abiraterone, enzalutamide or apalutamide, the second generations, or this LHRH antagonist, if you are using that, also can be used with abiraterone, enzalutamide or apalutamide. This is the NCCN guideline. So radiation therapy in low volume metastatic disease, as per the NCCN, is, as per the Stampede, it's androgen deprivation therapy also is added along with that. And they have noticed a significant improvement in failure-free survival and overall survival. And nodal disease, regional disease, as well as the brachytherapy, it's still in the context of a clinical trial. So in this patient, what we did was, it's LHRH agonist and kelutamide was given for 2 weeks, and patient's symptom, that's the back pain, improved, and he was on PSMA follow-up. At 3 months, 6 months, 12 months, 5.7 from the 30, it came down to 5.7 nanogram per deciliter. At 6 months, 2.3, and at 12 months, 0.4 nanogram per deciliter. And this in January 2018, and he came back with low backache again. And that time, we did a PSMA PET, and there was the original T5 lesion was there, and there was no new bone lesion, and PSA was 0.42 nanogram. And this medical radiation oncologist, radiation therapist opinion was taken, and radiotherapy was given. So what is your take, Professor Volkan, your take on this palliative radiotherapy to the bone?
This treatment is correct. So the radiotherapy given to vertebra, and then I advise the patient radical prostatectomy and lymph node dissection.
Oh, okay. You mean to say that radical cystectomy with radical prostatectomy with lymph nodal dissection?
Because he is very young.
Yeah. Okay. So this patient, radiotherapy was given to the vertebrae, and if it was multiple bone mets were there, will you advocate systemic radiotherapy in this case?
You know, the Stampede study is the low metastatic burden is very important.
Yeah.
So if multiple bone metastases, it's not necessary.
Yeah. Normally, as per the NCCN, it's 8 gray as a single dose, effective, but retreatment rates are very high. And radiotherapy to the primary site, suppose the patient is having obstructive symptoms due to the tumor, you can primary site again the radiotherapy you can give. And this patient came back in April 2019, and he was on regular follow-up with a PSA of 0.65 nanogram per deciliter. And that time, that PSMA PET showed there is a T5 lesion that was stable like the previous, and there was a suspicious lesion in the L2 region, and nodes were slightly regressed compared to the 2018. But patient started developing obstructive voiding symptoms. He had an IPSS score of 7/35. So during this, is there any role for an intermittent androgen deprivation in this, Professor Kalyan Sarkar? You have to unmute, sir.
I wouldn't think so, actually. He's got metastatic disease, and by and large, in metastatic disease, intermittent androgen therapy is not recommended. I also note that he's got a rising PSA. He's got clinically, he's got progression of the disease, and you should be checking his serum testosterone levels and to make sure that the androgen deprivation is adequate. And I think this is a point where one should really consider additional anti-androgen therapy or chemotherapy. And I agree with Professor, if there's a very good response, then the issue of radical radiotherapy to the prostate or radical surgery would be a bit, may help, but it may not help his, may help local symptoms. But
yeah, Professor Anshuman, in case if the PSA was normal, there was no biochemical, there is no progression of the PSA, and that nodes have digressed, will you advocate an intermittent androgen therapy in this patient? And if yes,
I wouldn't. I wouldn't advocate any intermittent androgen therapy in this patient. Well, I want to make another point here. Besides what you said, Mujib. So the PSA of 0.65 is still a fairly normal PSA for a young chap who has a progressive disease. So no, in my experience, at this stage, we have found certain other things that, which I mentioned earlier also, the neurocrine elements getting into this one, because 5+4 Gleason's, and we have burnt our fingers that we haven't gone back and rechecked the histopathology specimens. Even though we have done TURPs to relieve their obstructive symptoms, and on the TURP, we have found that the tumor has mutated. The tumor has, de-differentiated into a different kind of a tumor, and the PSA rise will not collaborate with the disease burden. Right. So the only PSA monitoring here is something that we have to look at it with high caution. We have to kind of take it as a disease progression and move from there. We have to change the line of treatment. Intermittent is certainly not something to be considered here. You need to stop the telutamide and add something else to it.
Yeah. The second generation, you mean second generation has to
be. May I make a point?
Yes, sir.
I think this is a younger man, and he is likely to develop progressive disease. This is the time to do some genetic testing on him.
Yeah, absolutely. Absolutely, totally agree with that.
Okay.
Can I make a point?
Yeah. Professor Volkan, anything to add on to this at this phase?
No.
Okay, sir. So this he came back. He was on regular follow-up. He came in on March 2020. The PSA at that time also was he had a stable, biochemically stable, like 0.62 nanogram per deciliter. PSMA showed no new bond lesions, but he had obstructive voiding symptom with an IPSS of 10/35. So he was subjected for the tumor board, and the consensus was to undergo for radical prostatectomy plus lymphadenectomy. So, Professor Volkan, can you just tell me, like, what is the rationale behind doing a radical prostatectomy? What is the principle behind doing a radical prostatectomy in a metastatic disease?
Yes, I think it is 2 points.
Yeah.
It's very important to point. This, first of all, when you remove the prostate, this tumor volume is very high. So the lateral pedicule dissection is difficult, maybe. So sometimes you can call the pathology in the operation. The lateral pedicule, if you remove after the prostate, you can perform frozen and to go to pathology. Sometimes the pathologist said that if the positive, you can do again. The second is the lymph node dissection, because this case is after the hormonal therapy. The lymph node dissection is difficult, maybe.
Yes, adhesions.
Yes, because the adhesion. So you must attention of the dissection.
Okay, sir. Okay. Okay. Thank you very much, sir. And this patient underwent radical prostatectomy plus lymphadenectomy on March month, and there was histopathology was Gleason 5+4, and he had a positive surgical margin at the left apex, and bladder margins were negative. Extracapsular extension was present, and 30 lymph nodes, all of them were negative except for common iliac lymph node, one single. So in this case, there is a left apical margin positivity and extracapsular extension, this thing. So is there a role for radiotherapy at this time, or any other form of management is required?
I think we recommend that pelvic radiotherapy.
Yeah.
In this case.
Oh, okay, sir. Dr. Anshuman, any comment?
Yeah. So Dr. Mujib here, since it is a metastatic disease and there's just a small, apical margin positive, I wouldn't bother about it, because you see, you are already having a metastatic disease. So how does a small apical margin positivity would hamper whatever you have done? So I would wait for the patient to become continent, and if there is any local disease recurrence later on, I would do a salvage radiation rather than doing an adjuvant radiation. It will only add to the morbidity of the patient who just had a radical prostatectomy. He's a young chap with metastatic disease, poor prognosis anyways, high Gleason's. So I don't think I will do a radiotherapy now. I would have done it before radical prostatectomy, but not now.
Yeah, okay. Thank you. Thank you. It was in June. This was on follow-up, and the PSA has come down to 0.2. And one more last point. Is there
Can I ask a question? Sorry.
Hello?
May I ask a question?
What is the role of the immune checkpoint inhibitors and other targeted agents as a first-line treatment? Professor Volkan?
Again, please.
Yeah, this one, the role of immune checkpoint inhibitors as well as targeted treatment as a primary modality in this castration-naive patients, metastatic castration-sensitive prostate cancers.
If after the radiotherapy, if the PSA level is rising, maybe I can use.
Okay. Okay, sir. Any?
May I ask a question here?
Yes, sir.
Hi, Mujib. This is Dr. Raina here. Is there a role for neoadjuvant ADT in high-grade prostatic cancers, localized?
Yeah. Dr. Anshuman?
Yeah. So, so while you are waiting for the surgery, sometimes, patients may get very anxious, and, we still are not very convinced with it. But yes, we are using for the time of, during the time of waiting. That is what we are doing. And we have not found any difficulty in the operation. In fact, the patient seemed very calm because they wait for 2 to 3 weeks or sometimes even 4 weeks before they get onto the table. So there is no harm in giving in high-grade cancers. You can do that.
Because there are reports now coming in of less biochemical recurrence, better negative margins, and so there are reports coming in. So that's what my question to you, the role of neoadjuvant.
So it will be a select group of patients. I totally agree.
And this patient especially had obstructive voiding symptoms developing.
Thank you.
Yeah. Any questions? No?
Yeah. Thank you, Mujib.
Yeah, sir.
Yeah.
Thank you very much, sir.
Thank you, Mujib, for discussing this. Thank you, Professor Olkan Tuju. I think it was really nice having you here. So we have 2 more cases to go. So are you going to step back, or you want to go on offline? Professor Olkan, you want to stay back?
Thank you. Thank you.
Because you are told that you wanted to go. So I think really it was very interesting to see the video. And in future, I think we have to have live surgeries here. So this type of webinars will not be sufficient for us.
I have to leave. Thank you. Thank you very
so much. Okay, thank you so much.
Thank you.
Okay.
Thank you.
Thank you.
Okay, and we will move on to the next case. This is moderated by Dr. Ganesh Bakshi. And panelists are Dr. Amit Ghosh, Manav Suryavamshi, and Rakesh Sharma. Ganesh, please.
Yeah, thank you, Dr. Yuvraj and RUF. I think the screen is seen, right? My panelists are Dr. who was logged in right now.
Yeah. Okay.
Dr. Amit Ghosh and Dr. Rakesh.
Yeah.
So this is the case history: 63 years, LUTS and back pain.
Enlarge the view.
Smoker on aspirin.
Yeah, we can't see the screen.
Yeah, now we can see the screen now.
I think it should be visible. 63 years, LUTS.
Yeah, it is.
And back pain for 25 days. Smoker on aspirin, lisinopril, clopidogrel with MI, post MI, on examination palpable. So after trying to void, he was catheterized with 750 ml. PRE hard prostate. The RFTs were normal yet. HB was 13, PSA 3500. Was a post-procedure one. So question is to Dr. Ghosh, do you relate an increase with respect to catheterization CRU, or it's directly in favor of carcinoma? I mean, we keep on seeing clinical things in practice.
I think in our practice, I wouldn't have seen, just because of catheterization and with the backdrop of clinical evidence of a hard gland, I would not suspect that 3,500 is a very high level cathetons. But this particular case, I would be in favor of thinking of carcinoma than anything else.
I mean, we are seeing PSAs which can be 150, 200, max 300, but never in thousands.
Never in thousands, yeah.
Further evaluation, the PSA was repeated and it came 25,030. The biopsy was adenocarcinoma, Gleason score 9, looked a PSA value of 10, so only 6 scores were done. Right? Again, sir, what would be your next possible investigation which you usually do in your real world practice?
Well, usually, I mean, not in the cases of 3,500 type PSAs. In the protocol, we have MP-MRI, and then we proceed to biopsy so that we don't get the artifactual rate. In this case, the options that you have given, the MRI plus
with a very high PSA, which suggests a metastatic disease, would you still go with an MP-MRI?
No, I would not, because you see, both your options are correct in my opinion. MRI with a bone scan or a PSMA PET. In this era of PSMA PET, yes, these investigations would help us assess the load of the disease, whether soft tissues are involved. That's the important thing about MRI or a PSMA PET. So I think on balance, we definitely can go for a PSMA PET just to assess the load of the disease, which I think is going to be very high anyway.
Yeah, I mean, I agree. I mean, so these were the images. If you see, it's loaded with metastatic. The prostate, which is highlighted, also is quite big in size.
Yeah.
Maybe bladder and other planes are gone. And then we come to the issues in this patient. So there is a high volume disease burden. There is a very high PSA. There is a pre-existing cardiovascular disease and LUTs actually with chronic retention of urine. So this question is to both Manav first and then Rakesh. Which ADT will help more and why do you say so?
Sir, I believe a GnRH antagonist would be more helpful because of the high volume disease, a cardiovascular pre-existing disease. So the cardiovascular instances are lesser, supposedly lesser in this case by extent of 56% and an absolute difference of 8%, and also a history of LUTs. So somehow it has been seen that the symptom scoring improvises better in GnRH antagonists.
Okay, so Manav has highlighted 2 points actually, cardiovascular history and LUTs, which would probably be better. Before Rakesh answers, Manav, your take on bilateral orchidectomy for these 2 things?
As good. At par.
Rakesh, your question.
Yeah, I agree to Dr. Manav. Basically, the high volume disease burden and patient might be severely symptomatic with painful metastasis. So there will be a very sharp reduction in all these symptoms once you give a LHRH antagonist. Similarly, the PSA reduction is much faster with antagonist and orchiectomy. So both will have a similar effect on the PSA value. Considering the pre-existing CV disease, antagonist definitely scores because there is almost like in the range of 50 to 60% reduction in the incidence of cardiovascular events for the first year in pre-existing cardiovascular disease patient. LUTS symptoms will be almost similarly coming down with both. But considering the CV benefits, I would like to go for the LHRH antagonist in this case. Definitely there will be a benefit, at least for the first year. Later on, we can always discuss with the patient.
So
Can I ask you something?
Yeah.
Choosing between the agonists and the antagonists, in the antagonists, do you think the additional role of FSH and antagonists would that stimulate any thoughts in you, Ganesh?
So there has been literature which is studied on mice with respect to FSH levels, and there has been a theory proposed with endothelial damage which happens because of agonists in the mice endothelium, and then proposed or extrapolated to the humans. There are, as the slide which is shown right now, if I show you that, if you see the orchiectomy thing versus GnRH agonist, actually in this slide there is no antagonist. But if you see the orchiectomy versus agonist, the levels or the percentages shown for orchiectomy are quite higher for the risk than GnRH agonist. So I think the research will still go on. I think going ahead with what Rakesh left us with is that this is the same data for Degarelix in 2014, which said that in patients with a prior history of cardiovascular disease, it reduces the CV events or deaths compared to LHRH agonists, as well as the 2019 data. Although the numbers are less, I mean, the Degarelix significantly reduced cardiovascular and major cardiovascular events with respect to GnRH analogs for pre-existing cardiovascular disease. And probably this question remains with Degarelix about the cardiovascular history, which should come out in 2020 or 21, probably with the pronounced trial. As Rakesh said, the PSA goes down very fast, but again, I would say that it goes down very fast with an bilateral orchidectomy also. Degarelix has more profound and sustained suppression of alkaline phosphatase, which may also happen technically with the orchidectomy. Degarelix associated with a reduction in musculoskeletal joint-related symptoms, which is vis-a-vis agonist, but a slight of these things will happen again with a bilateral orchidectomy, and significantly better LUTS control with Degarelix compared to GnRH plus bicalutamide, if you see this way. But if you total volume, it is slightly not increasing, and probably that is why it is thought that there are GnRH receptors on the urothelium of the prostate bladder area, and GnRH antagonist acts on that, and that is why there is LUTS relief. So this is one scenario, and Rakesh, I addressed this question to you. This was about ADTs. This is a slight different take on it. 70 years male on oral anticoag treatment, diagnosed with recent lower limb numbness, power 3/5. Doctor evaluated, it was a PSA of 2500, DRE hard nodular, and PSMA PET scan shows multiple metastasis and PSMA avid prostate. So the questions are there. Biopsy, will you do it? Will you start ADT? Yes or no?
So recently I encountered a similar patient. So what we did is we postponed the biopsy of this patient by a week. We stopped his anticoagulant for a period of around 5 to 7 days. And in the meanwhile, because the patient was severely symptomatic, but in my case, there was no paraparesis, but here appears to be a paraparesis. So this patient needs immediate ADT. And since only immediate ADT would be a LHRH antagonist, Degarelix, basically. So we will give the single loading dose of Degarelix to this patient as early as possible. And we can postpone the biopsy by a week by stopping the anticoagulants. and do the biopsy after 5 to 7 days. And definitely it is going to be a metastatic CA prostate, and discuss the patient about the further management in the due course of time. So the major advantage will be the reversibility. We don't expect in this case that the patient is not going to have a metastatic CA prostate, and then we can always decide what type of ADT we want to continue. But for the immediate relief, definitely we will start with antagonist, and depending on the neurosurgeon consultation and the radiation oncologist, we'll plan for the management of the spinal cord.
Rakesh, your take home is with such a high PSA, DRE which is hard, PSMA, avid prostate with multiple meds and anticoag, INR may not be normal because of the reversibility and the fast action you want. You may postpone a biopsy for some time and yet start antagonist on for an ADT, right?
Definitely, sir. Definitely we can do that because of the reversibility actions.
So one more question which I can ask to Manav or Rakesh also. There are occasions when we would probably go for a Degarelix. I mean, not always. I agree with everybody. So, what do you think? Now, generics are available. We have the research brand. Which would generally you prescribe or go for? Or you don't think there is a difference in any way?
Dr. Mano, you want to answer first?
So I think here we can give an option to the patient. In India, most of the times the financial status of the patient also starts defining the choice of treatment, you see. So if a patient is indicated for an antagonist but doesn't have the money, maybe you would prefer a generic preparation. But there are some people who say that they wish to go for the original molecule. Well enough, good enough, they can afford it, they should go for it.
Okay. Rakesh, your take on it?
Sir, fortunately, I work in a trust type of hospital, so we cater both type of patients. And in situation, we have to use the generic ones because it's almost the half the cost. Occasionally, we have used, but definitely the innovator molecule has the advantage. There are, as you have mentioned, cold chain and longer shelf life, pre-filled syringes there, and local. Yes, sir. Local side effects are lesser.
Debate right now in this.
Whatever the initial what I have seen, the PSA outcomes or the patient outcomes have been similar, but definitely the local side effects are higher when we use the generic ones compared to the original molecule.
Okay, so these are some indications where we go for a GnRH antagonist as per the slide, and the EAU 2020 does still say offer LHRH antagonist, especially to patients with an impending spinal cord compression or BOO. And the NICE, which May 2020 does say that Degarelix is recommended as an option for treating advanced hormone-dependent prostate cancer in people with spinal metastasis, and as per the NICE guidelines and the NHS from June 2016. So thank you. That's all. Back to Dr. Yuvraj.
Thank you very much, sir.
Thank you, panelists.
Can I ask a question here?
Please. I have all panelists.
Can I ask a question here?
Yes, sir. Go ahead. Go ahead.
Go ahead.
Yeah, see, we talk about a lot of cardiovascular side effects of agonists. See, there are about 23 participants, very experienced people. Do you really see these kind of side effects of agonists? How many times you have really seen the cardiac side effects?
Yes, can I answer, sir? Can I answer? Yeah. So now the problem what with was that we never looked into that. The people died. When the people died, we relate that to a prostate cancer. And nowadays, the more and more incidences of, this has been studied widely. The next most common cause of cancer, death in cancer prostate patient is cardiac toxicity. The first cause is cancer itself. First cause is cancer itself. That is widely studied. We have not studied in our country. The second reason is that there are many patients now post radiation therapy, post radical prostatectomy, they are on long-term hormonal treatment. These are the ones who are at really very high risk when compared to a metastatic high burden disease where they die of cancer easily. So I think there is a complete subset of patients which we are seeing nowadays after doing a radical therapy for localized or locally advanced cancer. They're coming back, they're on long-term hormonal therapy. And we don't check for ECG, 2D echo, cholesterol level. And many people have died and we label them as myocardial infarction, but we don't relate that to cancer. That's what my gut feeling, although we don't have any proof for that.
Even I agree with Dr. Yuvraj.
Like in the Western countries.
Yeah, even I agree with Dr. Yuvraj because I think most of, even as you say, 23 people here and many other urologists in the routine follow-up of metastatic CA prostate, many times we don't do a lipid profile, many times we don't do a 2D echo, and we ignore that, probably.
We actually do it, and the only thing is these are the patients who are always in the follow-up. They generally don't get lost to follow-up. So in my experience, this is very rare event. I mean, it is not more than the general public. You know,
Yeah,
in
I
India,
agree, sir. I agree. You are right because we have not looked into that. I think better to look into say around 100 patients come forward, and then we'll see how it affects it. Then only we'll be able to tell. Otherwise, very difficult to tell. Okay, so with that, I think thanks Ganesh. Thanks all the panelists. I think it was very nice. We'll go to the next case. Ravi,
Yes,
are you
sir.
there? Yeah. So next case discussion is by Dr. Ravi Mohan, and
Hello.
panelists are Dr. Amlesh Sheth, Dr. Imesh Gandhi, and Dr. Gopichand.
Thank you, Dr. Yuvaraja and Raf. This is a wonderful session so far. So we are at the fag end, and my job is to discuss about castrate-resistant prostate cancer. And for this, I have an eminent panel. Professor Amlesh Seth, he's head of the department at AIIMS, New Delhi. Gopichand, he is the head of the department at KIMS, Hyderabad, and Dr. Himesh is the director of robotic surgery at Pune. So, and I am at PGI Chandigarh. So let's go back straight to the case. He's a 65-year-old male with a very good performance status, no comorbidities, presented to us 2 months back in January 2015 with the complaints of back pain for 2 months. He had detected to have prostate cancer, biopsy showed adenocarcinoma, Gleason's 5+3. Bone scan had multiple bony metastases. According to charted, it was a high volume disease, and PSA was 54. So in 2016, we did not have this docetaxel add-on therapy as a standard of care. So that time we gave him only leuprolide 3-monthly depot and bicultamide. Instead of orchiectomy, he opted for leuprolide actually. And the PSA in next 6 months came to 0.3, a very good response. 6 months later, he developed a clinical progression in the form of new onset bony lesions, and you can see the that time PSA PET was done and it showed multiple bony mets. PSA increased to 2.34, and there was a progressive disease on PSA PET. So my first question is to Amlesh Seth, sir. How do you define a CRPC? That's for the residents who are listening, and how to decide the next line of treatment based on your experience?
The definition of CRPC is straightforward. What it states is that there should be a progression of the disease in the presence of castration. So there are two aspects. One is castration has to be established, and number two, progression of disease also has to be established. Now, castration, the definition of castration also has to be looked in very carefully, because if a patient has undergone a surgical castration, then the level to which the serum testosterone falls is less than 20 nanogram per deciliter. Whereas if a patient is on LH-RH agonist, then a level less than 50 nanogram is considered acceptable as being equivalent to that of castration. But I would, if a patient has gone into castration resistance, I would like to confirm the serum testosterone levels. And if the serum testosterone levels are, even if they are in between 20 and 50, I would not hesitate in advising a bilateral orchidectomy to this patient, because we still know that even in castrate resistance, the main line of treatment remains hormonal manipulation apart from chemotherapy. And second thing is the progression of the disease. If there is a clinical progression, then there is no confusion. Because if a new site has appeared or if symptoms have increased, then it is undoubtedly progressive disease. The confusion comes in a situation where there is just a biochemical recurrence. And how much of biochemical recurrence do you consider as an advancement? At low levels, I would tend to accept, unless and especially in a situation where the Gleason score is low. In this particular patient, the Gleason score was high. He had Gleason's 5 also. And patients with Gleason 5 can actually progress, given the absence of rise of PSA. Right. Now, talking about the question of how to decide the next line of treatment, in a patient who has castration resistance, the options that are available are further hormonal manipulation and chemotherapy. Now, how to distinguish, how to choose between chemotherapy and further hormonal manipulation? I would like to look at the Gleason score, the primary Gleason score. The primary Gleason score or Gleason grade is very high, which means that the disease is undifferentiated. And if the further rise of PSA is not that much compared to the load, basically that means that the patient is not likely to respond very well to hormonal manipulation, and therefore I would advise chemotherapy, docetaxel to that. In this particular patient, I would tend to advise docetaxel before going in for second-line hormonal treatment.
Thank you, sir. Thank you for those kind words. So that was done. This patient received docetaxel 10 cycles from Jan to July. So typically 6 cycles is recommended, but since you continue to have response, we give up to 10 cycles. And the PSA after 10 cycles did not reach the baseline Nadir. It was at 2.6. And however, PSMA PET did show a partial response in the form of regression of some lesions and stabilization of the activity of the other lesions. Then 3 months later, we do a PSA and it comes to 56 nanogram per DL. So a sharp rise in PSA 4 months later. So Dr. Gopichan, what would be the next line of management according to you?
Good evening, sir. Now we have done a PSMA and no new mets there now?
So in the PSMA PET, there is a stabilized disease.
Stabilized disease. But then PSA is rising. So one of the best thing that we have options of castrate-resistant prostate cancer. The sequencing include we all know now that there are options of enzalutamide, there are options of abiraterone. Today's era we have these many options. Docetaxel we have already given, so we have 2 options now, which is at present in fashion, we can say, according to the guidelines, enzalutamide and abiraterone both. Next slide. Abiraterone is one of the very good options here. Initially, when patient is fit, and both the trials they have shown that ADT with abiraterone in this group where docetaxel has already been given, he is one of the choice. Although some people would in fact think of enzalutamide also, but I will put this patient in abiraterone initially because of a bit of ease of the cost factor, everything.
Any specific things which you would look before you start on abiraterone, or how to monitor the patients who are put on abiraterone?
Yeah, definitely, sir. Abiraterone, I think one should look into the, in our group of patients, we have to look into the renal failure aspect also, and we have to look into the liver function, but more important than that is the liver, the renal failure aspect, the CKD aspect also, which we miss a lot of times. But otherwise, the liver function is also important. And there are certain side effects, dizziness, fatigue, low blood pressure because of the cortisol levels being low. So these things have to be looked into. And initially, when we start abiraterone, monitoring the blood pressure, monitoring the electrolytes, and initial monitoring of the LFT is very important. But most important is the blood pressure thing, which we'll have to monitor properly initially. And we all know this, the prednisolone should be given to lower the level for the cortisol compensation.
Thank you, Dr. Gopal. So he received abiraterone for the next 6 months, and despite abiraterone, the PSA continued to rise. So, and even the PSMA PET done this time in May 2018 showed that there was evidence of clinical progression. There was evidence of disease progression. So, Dr. Himesh, what would be the next option for this patient according to you?
This patient, anyway, he has received docetaxel and abiraterone. Now we have clinical progression as well as the radiographic progression, and he has clearly stated that biopsy was not possible. So, in this case scenario, we are not left with much options, and we will proceed with the second-line chemotherapy, that is cabazitaxel. We have ample evidence that cabazitaxel has been effective even in patients who have been refractory to docetaxel. And since the progression is less than 1 year, so adding a second line chemotherapy definitely is recommended in this scenario. EAU guidelines does mention regarding this, and the CARD trial which has been done shows clear. CARD trial was only for first primary endpoint was just radiographic progression-free survival, but subsequent analysis does show that overall survival was also better in a patient who have already progressed on docetaxel and abiraterone, and they definitely do benefit by cabazitaxel.
Thank you, Dr. Imesh. So this patient did receive cabazitaxel 6 cycles over a span of next 4 months. However, you can see on the right-hand side that the PSA did not show any response, although his biochemical parameters are acceptable, but the PSA continued to rise, and it was 122 at the end of cabazitaxel. And even the PSMA PET showed evidence of progression. So coming back to Amlish sir, what do you think should be done? So now the patient has a PSA of 122. He has got, and this is a typical patient which you would see in a clinical practice. He has complaints of significant bony pain and PSMA PET showing progressive disease. So what would you do?
Actually, now basically he needs palliative treatment. Palliative treatment is the most important. I would like to look at two things. Number one, whether he has a risk of paraparesis or not, which means whether he has a significant load in the dorsal spine or cervical spine. If he has significant load there, then I would advise radiotherapy in that area to prevent, or I'll also get an MRI done to see if there is a significant soft tissue component. If there is a soft tissue component and he has a high risk of collapse of the vertebra and high chance of paraparesis, then prophylactic radiotherapy I would like to give. Now, bony pain also I would like to see if he has localized pain, then localized radiotherapy can help. But if he has diffuse bony pain, then he'll be better off with one of the radioactive agents. Initially, we used to use strontium that was available in our hospital, and alpha-radon has not been available in India at all. And lutetium-177 PSMA is quite easily available in our hospital. That is what we use. The advantage of lutetium-177 over strontium is that strontium used to give mainly benefit in terms of bony pain. It would get concentrated basically in bones, whereas lutetium PSMA-177 also reduces the metastatic load to some extent. The lymph node metastasis and even hepatic metastasis, the load comes down. So even if a patient has visceral metastasis, then also lutetium-177 is quite useful.
Thank you, sir. Thank you for those valuable comments, I would say. So he had a local and did not have a localized pain. It was more of a systemic kind of bony pain, generalized bony pain, and there was no soft tissue. So we went ahead with lutetium therapy. He received 3 cycles of lutetium, and there was some PSA response, which
Therapy, prior chemotherapy status, and all these trials, the Prosper, Terrain, Prevail, Affirm, they all have something positive for enzalutamide. I think we should try enzalutamide in this patient, looking at the ease, and it is approved at all levels. The safety profile also, next, the safety profile also seems to be very good with enzalutamide. Except for the seizures thing, if the patient doesn't have any the stroke kind of thing, or we can do an EEG and then decide if there are no severe activity, then we must give enzylamide in this patient. There are very minimal side effects and not very costly today. The cost has also come down. So enzylamide remains a very good option at this level.
Thank you. Thank you, Dr. Gopi. So this patient was given enzalutamide and a PET-guided biopsy was done because there was some PSA response. However, the disease progression was there. So we did a biopsy. It did not show in small cell differentiation. Enzalutamide was given from June to December 2019. Despite that, and it is also known that once an abiraterone has failed, and as Professor Amlesh said right at the beginning, that he might not benefit with hormonal treatment much. So despite that, his PSMA showed progressive disease, bony pain restarted. So Dr. Himesh, what would you think now we are left with?
Here we have few evidence that once the biopsy is not showing any neuroendocrine differentiation, and there is still PSMA uptake in the bony lesion. So here still we are left with some options of having a targeted therapy with the radioactive drug. So right now, once the patient has failed on lutetium, the other option what we can give is actinium, because still PSMA avid lesions are present. And so actinium will be a very good option right now for his symptomatic bone pain, and as well as the PSMA progressive disease. So, but the only thing to be watched out with actinium is that it has a significant amount of xerostomia, and people have discontinued actinium because of this side effect. So the dose and the cycle has to be titrated according to the symptoms of the patient.
Thank you. Thank you, Himesh. So this patient did receive actinium. The only problem with actinium is it is very expensive. However, this radionuclide therapies, they have a very good advantage when patient has a generalized bone pain, which this patient had. So with actinium, he did have some PSA response, and there was clinical response in the form of decreased pain. But in the meanwhile, he developed retention of urine, underwent TURP, the biopsy of which was again adenosine, but this time the grade was 5+5. And in May 2020, 3 months later, so the duration of response was very short. In May 2020, he has this PSA progression to 121 nanogram. PSMA disease now shows multiple mets even to the viscera. He developed clinical trigeminal neuralgia. He had brain mets as detected on MRI. So what we did, I'll just go through it. So because anyway, it's the fag end of his presentation. So this time we did a somatic mutation assessment of the prostate biopsy tissue, and we found that there were the genomic findings where there was air amplification and ATM ataxia-telangiectasia mutated gene loss. And there is some evidence to suggest that when you have ATM mutation or BRCA mutation on a somatic gene, olaparib, the PARP inhibitors, might have a role. So this patient received 30 gray of radiation to his brain because he had neuralgia and brain mets, and olaparib was started based on the profound protocol. He received olaparib 600 milligram per day, and there were some issues because of blood transfusions. Olaparib was stopped in between. His platelet counts improved, his PSA improved. Now the present PSA is 35 nanogram. His appetite has improved. So clinically he has improved significantly. The only problem, as I prepared the case about a week back, he complained that he has a rectal pain, and we are suspecting maybe that his local disease started infiltrating into the rectum. So I think for want of time, we will omit it. I would request we can go through this profound study sometime later. It has definitely shown, if you have a clear-cut mutation identified on BRCA1, 2 or ATM, there is a significant improvement in median progression-free survival and radiological progression-free survival on a shorter duration. So I thank you all the esteemed panelists for their valuable comments. And also take this opportunity to wish all of you happy Teachers' Day in advance, because all of you have been teachers in one way or the other, either directly or indirectly through such seminars. Thank you very much.
Thanks.
Thank you very much.
Thank you, Yuvraja. Thank you, everybody.
Thank you.
Dr.
You are the
Yuvraj.
main teacher. We are learning. Ravi, one question from my side. You told olaparib. For this patient, did you do BRCA1, BRCA2, or you just give it clinically out of the?
We did the somatic mutation analysis of the prostatic biopsy tissue, the one which was harvested in TURP, and that showed it was negative for BRCA1 and 2, but it was positive for ATM. So for all three, the profound trial did use all three presence of these three mutations as the criteria for including. But however, there's a recent paper which says that a patient with BRCA1, BRCA2 respond better to olaparib than ATM mutation.
Okay, the next question is that, so now olaparib is not approved for prostate cancer use in India. So how did you use it? Like, it is very expensive, almost 4 lakhs per month.
Yeah.
How did you
So
use
as
it?
you went through the story, you would have realized that patient is reasonably affording, so he could manage. He has a lot of his relatives are staying in Canada with a lot of money, so he could manage all of it.
Okay. Because the reason why I'm asking is that olaparib in other cancers like breast cancer and ovarian cancer, they give it as a patient program or support program. So the cost is only 1 lakh a month. Okay. So for prostate they have applied, but we have not got it till now. So that's the reason patient may have to pay very huge amount of money. I think any other questions from any other faculty? Fine, thank you. I think it's time up. Thank you so much. And once again, for all the panelists and all the faculty, Chibbar sir and all the people.
Thank you.
I think
Thank you.
From my side again, sir, happy Teachers Day, Dr. Raina, Dr. Chibbar, and Dr. Amlesh Sheth. I think we are learning each other in a different way. Hope in future, I think we meet in person and learn better. And it's my duty to thank Ferring Pharmaceuticals, constantly helping to conduct these webinars, and they were also good in helping us in regular in-person meeting. I think next we'll announce in another week or so. So we are going to have a series of this is the 4th one. So we are planning to have penile and testicular cancers in the next meeting. So we will send you the invitation.
Thank you.
Thank you so much. Good night to all.
Good night.